We are recording, so let me get these alerts off. We are good to go. Good afternoon, everyone. We are sailing into Saturday. You know, we only do Saturday podcasts for some favorite people, so we're super excited about today. But good afternoon, everyone. This is Carol, so AKA Naughty West, live with two
Sistas. Hey, good afternoon, everyone. This is Janice, AKA Wellness Diva 5.0, live from the little circle. It is freezing cold in my office and it's almost 90 degrees outside. Go figure. So let's hop on into Sailing Saturday. We are so excited to welcome back to today's podcast, the famous TikTok doctor on amazing information about so many different things when you go under. Welcome back to Dr. Anthony Kaveh. Did I pronounce that correctly?
Kaveh. Yeah, Kaveh. That was good. That was great.
And we are so excited to have you back. Excuse me, when we had you back on in March, I just wanted to let everyone know, as I have quite frequently, my son is doing very, very well and blessed and grateful. And we know that, you know, sometimes with different medical things that pop up, and obviously you can certainly attest to this, you know, when you're in the possibility of having to go under, let's just start there. Like, what are some of the things, and I know we discuss a lot of this, but there's just so much to cover. What are some suggestions, or just kind of give us an update on where you are in what you're doing?
Absolutely. Well, first, thank you again for having me. As you know, a big fan of your show, and so thrilled to be back this Saturday. And for anesthesia, we call this probably the most mysterious branch of medicine for a reason, because patients certainly don't know what to expect unless they've had anesthesia before, in which case they still don't really know what to expect, because, as I think we probably discussed last time, either before the patient enters the operating room or when they're in the operating room, we give them medications that literally wipe their memories. So you actually don't know what happens to your body, except for some rare cases. What I personally do to help make this go smoother for patients, and we discussed this last time as well, is that I call patients the night before their surgery so that we can go through the technical parts of the anesthesia, what it's like falling asleep, if there's going to be a breathing tube placed, the chance of sore throat, hoarseness. I actually showed you guys some of the breathing tubes last time. And it's important to know, because if you're prepared for maybe having that sore throat, we can talk about tips, which are often natural, to help minimize or get that sore throat out of the way faster. So it might sound kind of scary, but it is important as part of the consent process to go through the technical things. By getting that out of the way the night before, on the day of surgery, when anxiety is at its peak and everyone's rushing and things are moving fast, I get to not have to focus on the consent part of the technical stuff. We actually get to talk about the experience of what's going to happen. You know, when you're having surgery, like, it could be this giant operation in your belly, in your chest, on your heart, lungs, wherever. But what the patient sees at the end of the day, or what they're going to remember, is, of course, the outcome. Did the surgery work or not? But also, like, they see the scar. It's like, what did that scar look like? That's part of the experience that they take away. It doesn't matter all the stuff that we do. That's our job. Ultimately, what the patient takes away is the experience. And that's what I want patients to have optimally experienced, or optimally to take away from this, because it can often be healing, like we said, to the mind as much as the body. But it's hard to do if you're rushing and just, you know, hastily saying hi to your anesthesiologist and signing the form and being shoved into the operating room. That's not a pleasant experience when you're maybe the most frightened or anxious that you'll ever be in your life.
Oh boy. And we chatted the other evening and yesterday. Well, Carol Sue, why don't you take it away? Phil, doctor.
No, I'm seeing a sports orthopedic sports specialist on Wednesday, and major issues with my shoulder, my hip, and my knee, all left side. So, you know, I avoided surgery probably, I think it was about 4 years ago, through therapy, physical therapy on my shoulder. it's rearing its ugly head again. So I'm a little nervous that there's probably a tear. The same thing with my hip. I have all the classic signs because my sister had the surgery already and everything that she described. And then of course I'm doing my, Google search, WebMD search, and I have all those classic signs. And then of course there's my knee. So I'm having issues with my knee. So obviously, I don't know anything. I'm sure the first thing they're going to want to do is an MRI. But I'm already got questions going into it just from the knowledge that you really, because if it goes that route of surgery, I'm already walking in there. I already have my list, and my first thing is, I'm not a good patient, so you better note that on your chart. And I tell that to any doctor because when it comes to shots, when it comes to, the anxiety that you speak of, I'm that person. And when you had really, really put it into perspective, which I don't think most patients even think about, but those of us that really struggle with that kind of an anxiety issue, that really is the step before death. And when and I'm not sure exactly how you worded it, you probably worded it a little bit more pleasant than I am, but ultimately that's, your body's in that state. And then, the next step would be, 6 feet under, basically. So of course I've got that wrapping in my head. So I've got quite a few questions, and one of them, if it is to lead to surgery, is I want to meet the anesthesiologist. I thought what you brought, which I don't think, as we chatted, that most people just don't think about it. The first time you have the interaction with the anesthesiologist is really, asking you some formative questions, on your health, introducing themselves, and then here sign off. And you're wheeled in, and typically, at least in my case, they're usually giving me a sedative before I even get to that point because I'm already, wound up. And, you may have a few other words, like, not necessarily like you say, counting backwards or whatever, but, here we are, we're about to put you under, yay. So I'm actually, if it goes to that route where I will need surgery, you've really opened up my mind and my heart and my ability to ask, certain questions of the anesthesiologist that I would never have even thought about. You really kind of put that connection together, that you're not just that you want to really make sure that the patient's comfortable. And I think that is something that I think all doctors on a whole, depending on obviously the specialty, but I think it's just a good practice. Makes so much sense.
Well, it makes so much sense. And unfortunately, when we're talking with insurers, sometimes common sense doesn't always follow through. But in this case, not only is the common sense absolutely there, but post-operative complications, surgical complications, blood clots, infections can all be less. Not to mention the chance of developing chronic pain from the acute surgical pain, nausea. I mean, the list goes on of things that even payers one day, or even today, should care about. So it's this kind of elegant mix of, it's a win-win situation for everybody. The surgeon wants it, the anesthesiologist obviously wants it, the patients want it. Nobody loses. It's just this example of how a system has been unfortunately built around a model that isn't right for anyone involved. It's not the patients or the doctors that benefit with the status quo.
Yeah, I mean, it just really, and from the healing part, again, it's a piece that most people generally, wouldn't necessarily think about, but it kind of goes back into that mode of, even when you're going to sleep, like, the old cliche saying, which there's a lot of truth to it, is don't go to bed, don't ever go to bed, angry, always go, in a more pleasant state. Really, stay off of your devices before you go to sleep. So, we know that there's things that we can be doing to really have even a better restful night's sleep. So it would so make sense at that point. That would be the same scenario with going into a surgery, especially where you are being put under, to go in there with a clear head, a peaceful state, kind of letting, things around you, just be more comfortable. And, I'm going to ask them to see if they can play some music.
Oh, yeah. I got to share a story with you guys because this just happened in the last week and I cannot stop thinking about it. And I thought that I got to bring it up, and it's so related to what you just said. This just blew my mind because everything you said is true about how at peace you are before you fall asleep, whether it be, your natural night's sleep or going to sleep under anesthesia. One thing that is additional to the anesthesia is that having trust in who's caring for you is also incredibly important, not only for reducing the chance of trauma, PTSD, et cetera, that might form after anesthesia, which is more common than we know. When you're sleeping at night regularly, you don't have to trust anyone how to sleep because you're just sleeping on your own, a little bit different for anesthesia. But that trust can be so powerful. And this patient story just really is demonstrative. So the night before, this was an elderly lady, over 70 years old. And as we're talking about the technical stuff about anesthesia the night before, she had a very, very, very unusual condition. I had never heard of this before. And I was a little bit validated in being told that she's seen all the specialists in the Bay Area, all the big name academic centers here, Stanford, UCSF, et cetera. None of those doctors had figured it out either. So I was like, all right, it sounds just so unusual. No one else has figured it out. Usually this is a sign of it being one of the, what we call multivariable, multifactorial-like conditions. It was a limb that was very rigid. So like imagine one arm being fine, but the other arm just being stiff. Very unusual in the absence of any like spinal cord disease or maybe something like multiple sclerosis to just have one random limb not move. And unfortunately, this can have implications under anesthesia. It can actually be very dangerous depending on what the cause of the rigidity is. So I had to ask, had to go into this deep dive. Well, it turns out that this all started maybe a decade ago after the loss of the patients, one of their children, in this terrible, horrific accident that really heart-wrenching. And suffice to say that all these symptoms started after a major traumatic event in the patient. I'm sitting here, it's not really my intention to go into something this deep, but obviously, like I said, for the safety of the anesthesia, we got to get to the root cause. I need to at least eliminate some of the conditions that might be lethal under anesthesia that might cause this limb rigidity. So fortunately, it was not concerning for the anesthesia. So we proceeded, the next morning when I saw her before surgery, we reviewed everything. A lot of anxiety, a lot of trauma held on in medical settings from the experience that this patient had to go through with the loss of their child. We go under anesthesia, surgery goes fine. It was actually pretty minor surgery, not even like, it wasn't like an open heart surgery, minor surgery. The first thing the patient said when they woke up, first of all, was thank you, which is rare, but indicative of somebody indicative of the preoperative state when they wake up. But when we were rolling into the recovery room, the patient is still not remembering things. So, when patients wake up after anesthesia, for the first couple minutes, maybe first half an hour, they might be having conversations, but they won't remember them because the parts of the brain that consolidate memories are not fully functional. The first thing they said when they rolled into the recovery room, maybe like 3 minutes after they woke up, "Doc, I think I have conversion disorder." My jaw dropped. Are you familiar with conversion disorder?
No.
Conversion disorder, and this is why I was shocked at why this patient even knew what the word was, is one of the most unknown and mind-boggling diagnoses in medicine, where patients may have some sort of severe physical ailment, usually in the form of their arm won't move, literally a paralyzed arm, with no reason to explain it. We have all these tests we do in medicine to rule out somebody, quote, faking it, because these just seem so far-fetched. Why would somebody wake up one morning unable to move their arm or their leg? We have all sorts of tests to trick patients into trying to move their arm, and I won't go through them, but it's neurologists and psychiatrists are well versed in these because a lot of patients, unfortunately, might try to fake it for malingering for insurance needs or whatever. You weed those patients out with these tests. And you have a whole bunch, and it's like, what are these conditions? Conversion disorder specifically relates to a psychogenic, something related to the mind. I'm not saying it's all in your, it's all in your brain, but it's not in the sense these patients are crazy by any means, but it is because something has happened in the brain where they literally cannot control some of the most fundamental parts of their body, like moving a leg to walk, moving an arm to write a letter or something. Anyways, not something that lay people talk about. And this patient, so coming back to the patient, they're still waking up from the anesthesia and they say, Doc, I think I have conversion disorder. First of all, patients hate the diagnosis of conversion disorder because there's a stigma in the medical community today that, once again, it's all in your head. You don't have anything wrong with you, which is clearly not true, but unfortunately gets interpreted that way by patients. So patients never want to say this and they don't want to hear it. So first of all, the patient who is telling me this, I called the patient 2 days later to follow up on this because I just couldn't get it out of my mind. They had no memory of telling me this at all.
Wow.
No memory whatsoever.
Yeah.
Turns out that not a single doctor has even believed her when she shared this with them. And they just keep doing injection after injection after injection and things that are all Band-Aid temporary solutions, which are nothing more than symptom relievers.
Right.
And it was just, it was an eye-opening conversation for her to have somebody, and I'm not building myself up here. Please don't get me wrong. This is not, the intention is not about me interacting with her. The point is what happened to this patient who simply trusted a doctor with their life, had a peaceful sleep, like you say, going to sleep peacefully with trust in your doctor.
Right.
How did that let this patient open up in ways that they've never been able to do before? She wasn't even remembering what, this was just on her subconscious that came up. And absolutely mind-blowing.
Well,
Unfortunately, no one's listening.
Right. And I think too, when we frequently talk about the mind, and there's so much to the mind that, that it's capable of that we don't even really connect the dots to, in all honesty, that is a testimony. So, don't set yourself short on that. That is a testimony to, obviously you put her in such a state of ease that really melted down into her subconscious enough for her to just come out and say what she had to say in such a way that, no, maybe she didn't remember, but something before she was under, you connected with, or she in her subconscious, you did, and she did. I think you should applaud yourself. That's amazing.
I think the amazing thing is that now she's empowered to go to all of her, she's got a whole team of specialists now, and she will tell every single one of them, I want to see, the doctor who's going to help address this being potentially conversion disorder and not just doing Botox. So what we do for rigidity, this patient had trouble moving their limb. They just inject Botox every 3 months, which, as you know, helps relax muscles, doesn't do anything beyond that, instead of addressing the root cause of why is this going on after such a traumatic event. It was painful to relive. And I don't want to obviously put patients in pain, but when this patient has not shared this story with anyone else before, and you set them, we prime patients, we can prime them before the state of anesthesia when their inhibitions go down and they can actually get a chance to reflect on themselves. And anyway, give the diagnosis. I believe the diagnosis in this particular patient likely stems from that. And they just said it themselves. They blurted it without even being fully awake. How powerful is that? How powerful?
Absolutely. Now, what would you, and I know I'm going to let Jan interject as well, but, what would you recommend for patients to, again, to me, it goes back to self-care. And I think Jan will agree with me on that. It goes back to self-care, really addressing, for me, I do it in a very comedic way. They think I'm joking and I'm a comedian, and I'm not joking. I would be noting my chart right now, and I give them examples of things that I've gone through, and a quick one, and to really enlighten whatever surgeon or doctor I'm dealing with. When I avoided surgery, they did give me a shot of cortisone. I'm not a shot person at all. That's one of the worst things for me. And, it was such a shot that they, was manipulating and really pushing it and doing what he had to do or whatever. And I'm like, oh my God, I'm so done. I'm like, are you gonna like cast it? Are you gonna give me a sling? And he's like, are you out of your mind? And I said, no, I'm dead serious. I gotta drive. And he goes, I thought you were joking. And he really thought I was joking. I said, oh no, I'm dead serious. You need to sling me. You gotta put a sling. He goes, are you kidding? And he just couldn't believe it. So he brought the nurse. He goes, is she for real? And I'm like, oh, I'm dead serious. I cannot drive. I need a sling. He goes, from a shot of cortisone? I go, hey, everyone's got their, and so I kind of, was joking with him at that point. I go, no, I'm serious. And so he finally did give me the sling and he put it on for me. And I was in that for like 3 days because that's how much pain. But when I went to another, she was a PA, and she said, no. She said, there are people that have, nervousness. So she said, I'm going to give you a shot. And I was due for some sort of shot. And I'm like, ugh, I can't. I just can't do it. She said, no. And she said, just relax a minute. So she did. She got me to kind of relax. And then she said, I'm going to have you bend over like an elephant. I'm like, what? She said, yeah, literally, but bend to your side and just hang your arm down there. I go, oh, this is fun. Okay. So I'm like hanging there. And so she's talking to me. And before I know it, she already did the shot. But because I wasn't so tense, the muscle wasn't so tense. And I go, that is, because I mean, I'll go as far as asking, like, what's the gauge of the needle? Like, I have to know. So I really think so for someone like me, which is not the norm, or maybe more the norm than people realize, I embrace it. And that's why I tell the doctor, what would you tell someone like me, for preparation, like not just that morning, like the day before, like, my thing is like I stay off of all devices, listen to music, maybe do some journaling. What would you recommend for the crazy patient like me?
Hey, thank you so much for sharing. That's beautiful, and it's by no means crazy. And if you think that you're in the minority for a hot second, I guarantee you are not even by a long shot in the minority. We're very blessed to see all walks of life, and holy guacamole, definitely not in the minority. Number one tip, which I hope everyone can appreciate, is that what you experience with the shot in the moment of any type of shot, which before surgery, you need to get an IV, except for the most minor surgeries, we have to place an IV so they can give you your medications. Mm-hmm. This is most often like the most stressful part for patients because they got to be fully awake for it. It's very rare that we give any sedation before the IV goes in the hand or the elbow area here or where. So tip number one, which works like a charm, we'll talk about why, is that I always ask well, first of all, I use a 30 gauge needle. So always ask for the babyest needle with lidocaine. I don't know why. I'm not bashing any providers out there, but some people just say, oh, they need to get a poke anyways. Might as well just put the IV needle in, and that's their one poke instead of getting one poke for the lidocaine and one poke for the IV needle. The difference is that a 30 gauge needle, as you know, is like the babyest needle out there. We do it in kids all the time because so right. Always ask for a lidocaine needle if it concerns you. Some patients legitimately don't care, so you don't have to do it, but ask for that. Number two.
Write that down right now. Go ahead.
Ask for the. And number two, what I do to distract patients is I ask them to cough as I'm placing that 30 gauge needle to numb the skin over the vein. What does coughing do? Coughing forces you to allocate your attention to something that's kind of voluntary, kind of involuntary. You have to engage all these muscles in your throat to cough. You actually have to focus for a split second. I know with COVID right now, everyone's like, what, you want me to cough? And it's like, yeah, just for a second. Just cough on 3. And when they're engaged in that cough, and you see, your eyes, like you get all scrunchy, you're focusing on, boom, I put that little bit of lidocaine in there. So what does this mean for the patient? Whenever I'm a patient getting whatever, a shot in the arm, I say, hey, let me know when you're, give me a countdown to 3. I like to cough. I'm just warning you, I'm going to cough. So I tell them what I'm going to do because most providers don't say this. So that way I cough. So I'm focusing on all my throat muscles and coughing and not getting COVID from, like spreading it to anyone. Anyway, you don't even feel the needle go in practically, right? So your thing of bending over this way, that works as well. Remember, the more loose your muscles are, theoretically, the fewer muscle fibers that needle is going through, the fewer muscle fibers is going through, the less tissue trauma. The less tissue trauma, the less pain. So that's the idea why having less tense muscles is helpful. But just distract yourself. Now, distraction is not a good long-term coping mechanism. Definitely not. But for things that are episodic, like before surgery, you're not getting IV needles every week, every month, hopefully. In those cases, I absolutely embrace distraction, because we're not talking about like dealing with a trauma that you're going to have to deal with for the rest of your life. No, distraction is not a good way. In cases like this, 100% embrace it. Anyways, cough, number one. The other part of what you're saying, which is the deeper question, how do you prepare for something as traumatic as surgery? Unfortunately, there is no playbook, because every individual is different, and it's not a cop-out. It's that the experiences, the medical history that you bring into the operating room is fundamentally different. If you've never had surgery before, you're not going to have PTSD from an operating room. If you had a child die from surgery before, you're having a whole different set of traumas bringing in. If you had surgery before and the chronic pain is destroyed your life, you have a whole different set of traumas. If you're overweight, if you have heart failure, if you have asthma, whatever it is, there is no one size fits all plan. However, there are three general pillars to preparation. And those are the mindset, the physical conditioning, and the nutrition leading up to surgery. Those three are shared for anyone who comes in for surgery. And unfortunately, none of my patients know this, and I really mean none. And certainly nobody optimizes all three of them. It's not anyone's fault. It's no one, I'm not attributing any blame, except the system does not foster this type of preparation. We're starting to in some places. Kaiser Permanente here in California is trying to do it because they're a payer and an insurer. So they want to cut costs, and they know that this, and we began the session today talking about how you can actually save money and save lives, which, everyone's in the same boat there. Kaiser does a little bit of this. My wife had surgery recently, so I kind of went through all of their free surgery materials, and I'm like, oh, they're like 15% there. That's cool, more than anyone else. So I'm happy to talk about some of the components of those three pillars that are broadly applicable, but it does always depend on the individual.
No, I mean, don't you think, Jan, those three things, were really, three of the things that we always talk about all the time, which it would go into play with, that whole prep.
Oh, absolutely. And I just want to reiterate, that was mindset, nutrition, and fitness. Because I was trying to
physical conditioning or fitness. Exactly.
Yeah.
Exactly. And you can go by different words, right? Mind body can be interchangeable with mindset. Mental health can be interchangeable with mindset. That's one, right? The nutrition is your diet. If there's any supplements you're taking, et cetera, that, that's the broad category. Then the physical fitness is like your conditioning. It's not necessarily just like your VO2 max with like a Fitbit or whatever. It can be much more simple than that. But ultimately, how well can your heart tolerate the stresses of anesthesia and surgery? Three broad categories.
I do have a recommendation for you, Doc, if you don't mind me commenting. Do not, under any circumstances, give your telephone number to Carol Sue. Obviously I don't want my sister to undergo surgery. But
fingers crossed. The MRI, we'll get through that first. So that's another old creepy thing, but whatever.
I do have a question though, because I'm really curious about this. You had mentioned going under, is such a mysterious branch of medicine that when the patient wakes up, they have no memory. Have there been studies or any patients that you've worked with that have had some type of memory of what transpired?
Oh, wow. So now we're going into some of the really juicy parts of anesthesia. To answer your question, yes, I had a patient last year. It was intentional. I purposely did not put them very deep because they had a history of certain anesthesia complications. We had a conversation beforehand. It did not lead to any traumatic event at all. They had some recall, which was not unexpected at all. But what you're referring to digs into something much deeper than just some of these anecdotal experiences, because unfortunately, I should say, fortunately, anesthesia awareness is quite rare. It's on the order of 1 in 1,000. just so people know, we have awareness when your dosage of anesthesia is insufficient for your anesthesia requirements. So like your brain needs this much, you're getting this much, that delta, that gap leads to your brain still being a little bit awake. The problem is that even if your brain is a little bit awake, it cannot necessarily form memories coherently. And this leads to trauma that unfortunately patients may not be able to even remember.
Wow.
Which is problematic. If you're trying to diagnose somebody with new depression after surgery, new hyperarousal after surgery, new anxiety after surgery, new symptoms of PTSD after surgery, you go into like, well, what happened to you in the last couple of weeks, months? Some patients very, very rarely will say, you know, I heard voices, I heard people in the OR laughing, joking, I felt the instruments on me, I saw something. Those cases are terrible. They are pretty rare, like I said. And yeah, at least you can circle back to then address that trauma. And we can talk about how you prevent that from happening in the future. There's all sorts of techniques we have. But the one that's less, or the one that's probably far more common, but we can't diagnose it nearly as easily, is when patients don't know what happened. It usually takes about 2 weeks for the memories to begin to consolidate enough to even put one and one together that, oh my gosh, those voices were me in when I was supposed to be under anesthesia. But
Right.
There's, like I said, dose discrepancy for many different reasons we can talk about why that happens. So for one, you have a delayed diet. I mean, patients don't even know what's hit them because you just had a shock and awe from surgery, right? And then number two, patients aren't, I mean, do you want to go up to your doctor and be like, doc, I think I felt my surgery? You know, I don't quite know what happened, but I have this feeling that something weird happened to me. Patients are afraid to bring this up with their doctors. Doctors don't know how to interpret this because what I'm sharing is not widely taught in medical school, and it's certainly underdiagnosed, and we just don't know enough about it. But it's almost like how many patients have had some weird thing happen to them under anesthesia, but their brains haven't even, and it's not their fault, right? It's because your brain isn't fully online. It can't put all these memories together when it's scrambled under anesthesia, even if it's only partially scrambled.
How do you determine, like, because you're talking about the different levels of that somebody goes over? Is it based on weight? Is it based on time that you're thinking that the surgery is going to last? What determines? Because you're talking levels, so I'm assuming not everyone's, everyone's different.
Another fascinating question. We think that anesthesia, I should say patients think anesthesia is just like a light switch, on and off. Absolutely not. There's different depths of anesthesia. In fact, in the first stage of anesthesia, you're kind of what we call hyper-excitable. You are moving around a lot, and it's dangerous for the surgery. So we actually need to quickly descend past that. We call that stage 2. Doesn't matter the name, but that's not a safe place to be because many complications can happen in the body when the brain is kind of halfway off. Almost think of like an agitated drunk. Alcohol can be an anesthetic. It would kill you at the doses needed for general anesthesia, but it acts on the same receptors as many of our anesthetic agents. So imagine a very angry drunk, but even more volume cranked up. We need to descend below that to have the body be completely calm. And then presumably we put a little bit more in as a safety buffer to prevent memories from being consolidated. The problem is that weight, which is our first and foremost metric for dosing, and age only can take you so far. Because once again, every patient's different. What patients bring into the operating room also determines what their requirements are. Those include funny things like red hair. Maybe you've heard of redheads needing more anesthesia. There is some truth to that. Very, very common question, by the way, on social media. Very common question. The bigger one, Ehlers-Danlos Syndrome. I don't know if you've heard of it, or I'm sure your viewers, another condition where we believe there might be some increased anesthesia requirements. But putting those aside, high anxiety does increase some anesthesia requirements. Alcohol use certainly increases anesthesia requirements. Other drug use. What we're seeing a lot of in California is marijuana use. Absolutely higher requirements, far more than would be predicted for your age and body weight alone.
Wow.
So all of these things that we put in our bodies, drugs, or probably even foods that we haven't yet figured out, influence how much you need to actually be amnestic or to be fully knocked out. Now, patients are often unwilling to tell us, and they're afraid of social stigmas, et cetera. They won't tell us how much weed they actually use or how much meth they use or cocaine or whatever. But all these drugs, anything that affects your brain, kind of exposes itself under anesthesia when that book opens up. One way it exposes itself is in the anesthesia requirements.
Wow.
Wow, that is so fascinating to me because, you had mentioned, I picked up on this one, hyper-excitable.
Yeah, absolutely.
Well, with good reason. And as a sidebar to that, when they have started the IV on me, I'm just like, I get a little tense. So, I try to remember, okay, focus on my breathing, focus on a pleasant memory, something like that.
Maybe you can cough now, right? Focus on that cough, those throat muscles, engaging them. This is suggestion.
Yeah.
Exactly.
Sure.
And I can hear, again, we don't want her to undergo anything, but I can hear her directing the conversation in the operating room. All right, everybody, cough now. But
the good thing I can say is I do not use marijuana. I did in my younger years, and I would get paranoid, and then I would go eat. So that is why at least I can say my mind is not subject to that stuff. So that should help me.
Good, very good.
So what we were just chatting about the question I asked, and you had mentioned that it's quite rare, 1 in 1,000. Is that something that the medical association or whatever, like, does somebody keep track of that? I'm just like really curious about this, because I would think that as these cases do come up, they're obviously so unique and diverse that the medical community, I would think, in turn can learn so much from that.
Great question. So there's a little bit more to the story than I shared, because the other part of the discrepancy between dosing and requirements is if your body cannot tolerate the anesthesia. So if your heart can't tolerate the anesthesia, you're at high risk of being underdosed. So this specifically comes up in some predictable patient populations, to the point of your question there. One is obstetrics, so emergency C-sections. 2 is trauma surgery, and 3 is open heart surgery. All 3 of these patients have hearts that cannot tolerate an otherwise full dose of anesthesia. So that is now lowering the amount of anesthesia you can give. So even if you have the, I want to say cleanest brain, whatever, the brain with the lowest anesthesia requirements, if your heart can't tolerate enough, because you're bleeding out from a car accident or a gunshot wound or a stabbing, or you're a mother on the operating room table who's lost 1.5 liters of blood from hemorrhaging from any number of placental abruption, et cetera, your body can't tolerate the anesthesia. These 3 populations are at highest risk. So that 1 in 1,000 number is an average, but we do know who's more likely to experience it. So people with the higher anesthesia requirements, like we said, chronic alcoholics, cocaine abusers, et cetera, and people whose bodies can't tolerate. And that's going to be obstetrics, emergency surgery, and open heart surgery, just because those patients who are having open heart surgery already have the weakest hearts in the world. Hence why they're getting open heart surgery.
Yeah. Fascinating.
It really is. And, I wonder, from those 3 experiences, what that ultimately does for the patient themselves. For instance, you'd mentioned alcohol, like say somebody is maybe in a car accident and it was alcohol related, and their level of alcohol is so high. And, you've heard sometimes that, I didn't feel, or they didn't feel a thing type of thing. So, that's frightening for different patients. Getting to the root cause, the root cause, I don't know. Like, I think that there's so many unanswered questions with that. And I find it fascinating.
Yeah, I need to share something else on that topic, just because you mentioned alcohol in particular. Acute alcohol use actually lowers anesthesia requirements. So if you come in completely drunk, you actually don't need as much, because like we said, you're already halfway there. So in those cases when patients, quote, don't feel anything, it's because they're already, if their blood alcohol levels are high enough, partly already anesthetized. About this whole topic that we haven't talked about is that what happens when someone does have awareness. We talked about those possible complications of mostly related to mental health, which then eventually manifest in the body as physical ailments, but like the PTSDs, hyperarousals, chronic fear, feeling isolated, etc. What's really important for us to remember is that there's still things we can do to help minimize those risks. So I mentioned earlier, like last year I had a patient who I purposely underdosed their anesthesia, very, very intentionally, but they didn't wake up with trauma because of some very particular things that I did. It turns out, and this is not surprising to people like yourselves, because this is very intuitive. Unfortunately, the intuition matches the data here. Patients are more likely to experience a traumatic event and then consolidate that memory as a PTSD type memory to live with PTSD after. Because many of us have traumatic events who don't have PTSD after. We've all experienced people dying, accidents, et cetera, et cetera. Most patients and people will not classify that as a PTSD event. They'll live their lives without hyperarousal, chronic fear, and the physical complications from it. Why do some patients have different brain processing of that event? So turns out that at least in the operating room, which is likely going to be extrapolatable outside, the more patients are afraid for their life, fearing that something is going wrong, they are likely to, and once again, it's kind of like common sense, more likely to develop PTSD from that intraoperative awareness. Among a couple other factors, but most of it boils down to the more fearful you are. Yes, if you have pre-existing PTSD, pre-existing anxiety, depression, et cetera, these increase the risk as well. In my role, what can I affect? I can't go back and change 15 years of a patient's traumas before surgery. It's infeasible to do that, but I can remind the patient that they are loved, cared for, guided. You know, that's why we called the night before. It's why we want to build that therapeutic relationship so that if something happens and they hear something, the hearing parts of the brain are most resistant to anesthesia. So if you're going to remember something, it's usually something that you're going to hear. Like the common thing is patients that have wisdom teeth removal and they say they were awake for it, they'll usually hear drilling. They usually don't feel pain because we give so much pain medication. They might hear weird things. So I want them to hear that, so that hear the most important person to me in the world at that time. And you tell me, how do you think that you would, if you were a little bit awake and you're hearing that type of voice instead of people freaking out or making jokes about you or whatever it might be, who's more likely to develop this PTSD from this? It's why we place headphones on patients' ears that repeat positive affirmations, or quite frankly, whatever they want, whether it be music, like you said earlier, something that's peaceful and calming and relaxing to them. So that if something is a little bit online in their scrambled brain, they're hearing something relaxing, something that is not going to have them fear for their life, be afraid of dying on the table.
Oh, yeah.
They're less likely to consolidate that partial memory in this inexplicable PTSD pattern from awareness.
Yeah, it's just fascinating how, you know, what the brain absorbs, what it hears. And, you know, they often say, you know, especially when a person is really in their last hours of death, for the most part, their hearing is the last to go. So that would make common sense. You know, the same thing when you're under anesthetic, that your hearing is still there, even though you're in such a state where your mind may not be absorbing everything, but you're hearing. So that, I think that's fascinating.
It actually makes it very difficult.
The dynamics of the OR, like, hey, how you doing down there? Like, you know, you're wondering, can you hear me? I'm going to be imagining that now. Yeah.
This is actually another very common question. You know, we do listen to music in the operating room during surgeries. And there are conversations that happen. There's nothing wrong about this, because if you're trying to like just focus nonstop on something for 2 hours, it becomes very fatiguing. And I think that for many people, you're going to have worse outcomes because you just get mentally exhausted. There's something to be said about the balance. And it's really an elegant balance of safety and the best possible outcome for the patient. And how do you bring in some level of fun and enjoyment so that you reach a state of flow? If you want to talk about, I'm sure you guys have talked about flow before. Flow is not just staring at, an appendix for 45 minutes and trying to dissect it out and rip it out. No, it's about doing that in a non-fatiguing manner so you still have juice for the next patient of the day.
I have a question.
Oh, here she goes.
You would mention that obviously you have conversations, and that's, I would think that obviously that you're not, like, as you said, just so focused on that appendix. And obviously you don't have to go into great detail. What do you think is maybe the wildest conversation you've ever heard or been a part of in the operating room?
I'm gonna have to plead. What is it? I would be dishonest if I told you.
All right, let me ask the question this way. And again, you don't have to answer this. Has politics ever been discussed in the operating room?
Ooh, politics has been. And any wise anesthesiologist will tell you that the best course of action is to steer clear, because
I would think, absolutely, yeah.
Religion, politics, and money are 3 things that we should not be brought up in a professional environment, because you don't want heated arguments or discussions.
Right.
On the table. Then this isn't flow or fun or entertainment. This is now becoming a patient. I'm sure nothing bad would happen, but I would not roll the dice, even if it was a 1 in 10,000, 1 in 100,000 chance. Why would one engage? Fortunately, in my experience, I'm very lucky to be working in the Bay Area where people are not. The surgeons that I work with are not typically aggressive. I think in most centers, it's not a real concern.
Yeah, no, I wouldn't, I'm just wondering if I'm sure there's some like juicy stories, like something like, just fun and juicy and.
You can't talk about it.
I know.
I'll tell you that patients.
But I would think that they would want to, just be, so relaxed and in tune and, working together that you talk about things that are relatable and fun or relaxing or, that are not controversial. That, and just humor. For me, humor cures all. So,
humor is another very powerful secret in medicine. Very, very powerful. If you look at, oh my gosh, 1 minute story here, just because humor is so powerful. Maybe did we talk about Norman Cousins last time? Maybe we did. I think we did. Ankylosing spondylitis.
I don't recall.
No.
Debilitating autoimmune disease where your spine literally fuses from just nonstop bone growth and scar tissue that just forms around your spine. Before we had modern medications that could help prevent and treat this, patients just had to literally take ibuprofen all day, every day, suffer the consequences of that, and live in a lot of pain. Norman Cousins, you can look up the story, I think it was the late 60s, was hospitalized for one of these, terribly painful episodes from their ankylosing spondylitis. And it was just so sick of the hospital not helping him feel better, checked himself out, went to the hotel next door and just watched comedy on whatever, I don't think they had VCRs back, whatever they had on TV, just laughed it off and felt so much better. Went on to talk about the experience. But anyways, humor is an incredibly underutilized and safe part of medicine. That story is just one of the hilarious stories that people don't really, unfortunately, share, because we have so many medications that work today, but we forget about the other alternative and very, very safe methods.
Absolutely. Humor cures all, I believe. What do you think, Jan?
Oh my gosh, yes. I've often said, like, if I'm having maybe a bad day, or if I know that I need to get up and kind of lighten the load, I go in, I'll go in the bathroom, look in the mirror, and I'm like, hey, how you doing? And that makes me crack up. And I crack up for like, however long, and it's just me. And then I'm like, oh, I feel so much better. So definitely a lot of truth with the humor. That goes such a long way.
And biochemically, we have some inklings of why that is. And I just had to mention it because we talk about anesthesia in the operating room. The medications that are used that often turn into drugs of abuse, things like opioids or marijuana in the use of cannabis use disorder, they act on receptors that we already have in the body. Endorphins,
Right.
endocannabinoids. But there's so much emphasis on looking for external sources to stimulate these receptors that we forget that our bodies are also capable, as you just said yourself, at stimulating these receptors within our bodies, not only to reduce pain in the case of endogenous, meaning they're already in our bodies, endogenous opioid receptors, that we have endogenous opioid receptor agonists. So we don't make morphine in our body, but we make weaker forms of it all the time that we can increase stimulation, increase production of. Same goes likely for endocannabinoids, et cetera, et cetera. Without the side effects of an opioid epidemic, of cannabis use disorder, of et cetera, et cetera.
Wow. All right, now I have a question about something about nothing.
Okay, here we go. Let's go.
When you were a child, did you have that game Operation?
Did you enjoy playing that game, Janice? Was that your go-to as a kid? Were you good
Yeah,
at that?
I love that. I love that game.
She liked the noise.
Which was your favorite piece to pull out?
The bone.
The bone in the leg. The bone in the leg.
Yeah.
Yeah.
Like,
Why?
well, I don't, you know what? I don't know why, but I think the noise, like Carol would mention the noise, like you're so, you mentioned about the, the appendix, like you're just so focused on just grabbing it out of there and being successful at it. Like all your tension, you have tunnel vision right then and there. You just want to rip it out without getting zapped.
To me, that was the easiest piece to get out because it was long.
That's what I was thinking. That was my personal reason. I love the bone too. It was the easiest one.
Easiest one.
Well, there you go. Do you have any?
Do they make that game anymore? We'll have to find out.
Yes, they do.
Oh, they do.
Yes, they certainly
Mm.
do. Do you have any something about nothing questions?
No, I'm writing down my notes because I'm going to have a ton of them when I meet with that doctor. I've never met him. I've heard very good things about him. And so I'm, I've got some other questions and, I may even ask him if I can, meet with the anesthesiologist, if that's the route we go beforehand, which is probably an odd request, but I don't care.
And Doc, also, we're going to be in California next week. I will make sure that she doesn't have your address.
That's right. We're flying into San Diego. I'm like, where is he located?
Oh my gosh, this has been such an amazing conversation. I sometimes think, Carol, so especially with having you on, Doc, amazing that we think we cover all that we need or want to, but yet we discover so much more. It's fascinating, absolutely fascinating. Any parting words, Doc?
Oh my gosh. Well, I want to say the human potential is equally fascinating. The more we learn about what we can do, the more we realize that there's more we can do. And, surgery when needed can be life-saving and powerful. And it's what separates us from medicine from 1,000 years ago. But it's not always necessary. It really is kind of like the pinnacle, but we have a whole foundation of that pyramid that we can address before we get there, obviously. And I'm just curious if you guys if you would be comfortable sharing an experience where you feel you were able, something that could maybe, I would love to be inspired and enlightened by, I'm sure you've had them, experiences where you tapped into something that you felt you couldn't do before, but you found the strength to do.
Wow.
I'm putting spot. I don't mean to, but I'm just so curious.
Carol Sue, you go first because you're older.
My memory isn't as good as yours. You go.
Well, the first thing that popped up for me was, well, I'm going to be 60 on Tuesday, but at my 50th surprise 50th birthday party, I fell. I immediately knew I tore, I had a tear in my rotator cuff. 2 operations within a year, major hip surgery. And what I remember, and I believe it was from the hip surgery, from being under, was they had asked me if a representative, because he knew he had to put clips in my hip. So I guess that representative happened to be at the hospital, and they wanted to be in the operating room with their product that they were going to put into me. And of course I was like, well, I don't really care. That was something significant that I remember. But what I remember, I think I may have shared it beforehand, was my height and sensitivity for chocolate. Like that must have been on my mind, like chocolate, chocolate, chocolate. Like I had that tunnel vision, like I had to have dark chocolate. And I guess I was making everybody crack up. But the other thing that I wanted to share was obviously from Ryan's experience, I was thinking of, and I was having a conversation with him last week, and do patients ever recall, like he doesn't remember those first 2 weeks when he initially had his accident. And I'm just wondering, do you have patients perhaps that have been through a traumatic experience and they don't recall anything? They only remember it from a certain time frame, typically past what the accident date was?
That can happen in patients that have insults to the central nervous system, aka the brain, because anesthesia scrambles memories, but physical trauma also can cause amnesia, concussions, etc. When you have surgery in somebody who has had an insult to the brain, like a bad concussion or a bleed in the brain, or if there's a tumor, if it's a non-accident type of thing, mixing anesthesia with already disease in the brain can lead to increased amnesia thereafter. So all bets are off on predicting. In general, the younger patients are, the more what we call cognitive reserve they have, the more likely they are to have a shortened period of amnesia, just because they presumably have more neurons firing, more cylinders, firing. But it really depends on what the mechanism of the accident was and all that.
Gotcha. Okay. Thank you.
Wow. Well, I would have to say I had two C-sections. So the first one was, he was breech. And I remember vividly our mom coming in after after they did the operation. And I remember her just leaning down, and I'm a type of person, I have to sleep with socks on. My feet are always cold. And I vividly remember this, and it's always stuck with me because other parts, I don't remember anything. Why are my feet so cold and where are my socks? And then she says, oh, we're so grateful, so blessed, you gave us a grandson. I go, I don't know what you're talking about. The kid is still inside of me. I have not had any surgery. She goes, I don't know what they're telling you, but that kid is still inside of me. And to this day, I don't know that I could connect the dots as to why I thought that, but it was very odd. And I remember saying it, but I don't know why I thought that no, he was still in me. And she's like, no, he's not with you. He's in the back, the little crib thing. And I'm like, my feet are cold and that kid is still in me. So, I don't know. That's me.
No, but that is such an interesting story that just shows the tricks that our mind can play on us in moments of vulnerability and fear. I mean, I'm not saying you were afraid or you were traumatized and you were stressed, but many women in that situation, especially if it's, breach or something unexpected had happened, points to that when we're vulnerable, our minds play tricks on us, and we're it sounds like a scary thing that our minds play tricks, but it also means that we can be suggestible for other outcomes to happen. So there's actually a lot of opportunity in exactly what you just said. if you know it's going to happen, which, in the time of surgery, I don't know how elective or non-elective your C-section was, but it makes you wonder in women that are having these kind of frightening moments, how much can we harness the brain being a little bit suggestible to help promote ideas that'll help them have less pain after delivery, better chance of bonding, better chance of breastfeeding, better chance of protecting against horrible things like postpartum depression or baby blues, which is very real. How important are those vulnerable moments in our lives when we have people that care for us, that love us, and that help guide us?
Right. And the second one, which this is actually funny and not funny, but funny. The second one was scheduled, but I was doing a spinal. And I think I talked about how the anesthesiologist kept missing his mark. And my, leg would just kind of make this like, out. But anywho, when I got back to the room, they were supposed to leave the catheter in because I had a spinal and they wanted me to, the spinal was from my neck down to lay flat. They didn't want me up. Well, inadvertently, they took the catheter out and my husband wasn't in the room. The nurses weren't in the room. I'm like, yeah, I got the urge to pee here. What the heck is going on? And I knew I was supposed to lay flat, but damn, I was not peeing in that bed. So I don't know how I did it, but I got myself out of the bed and I crawled to the bathroom. And now I'm in the bathroom and I'm trying to get the energy, which I don't have because I'm still very wobbly. So the nurse comes in, my husband comes in, he's like, where is she? And I could hear them yelling some code that there's a missing patient. I could hear them running. And I'm on the other end of the door, or the bathroom door. I'm thinking, I'm punching this door. And I'm laughing and crying at the same time. I'm in here, help me. And I'm thinking I'm yelling. I think I'm hitting really hard and I'm not. They finally do find me. They're like, how did you get in here? You weren't supposed to get out of bed and blah, blah, blah. I'm like, hey, this girl had to go to the bathroom. I wasn't peeing in that bed. And I only remember bits and pieces of it. I do remember banging on the door. I could not tell you how I got out of bed. I don't remember that whole process of how I just remember I could hear them looking for me and screaming, and I was trying to let them know where I was. Other than that, I don't remember anything.
Wow.
I got some crazy stories. And this is why I'm not a good patient.
One other quick question, nothing about nothing. Have you ever had to put socks on somebody's feet?
Yeah. Maybe I'll end by, this is not a judgmental statement at all, but in medicine, we see a lot of feet. And some are definitely, I'm not once again, no judgment, please don't take this the wrong way. Some feet are better taken care of than others though. When you have nails curling around multiple times, it does suggest, something about self-care or lack thereof. Mm-hmm. So there's a saying in medicine, I'm not condoning or disproving or refuting or anything, I'm just sharing. Mm-hmm. A common pearl of medicine, not my judgment, but we say that you can learn a lot about a patient from their feet. So when you're putting the socks on or taking them off for whatever reason, sometimes I need to place an IV in the foot for any number of reasons. I get a good look of the feet and how they look and how they smell and what's going on. Yeah.
All right, which leads me to another question.
Oh my God.
So that old saying, or maybe this is more of a comment. I forgot who did the skit about it, but you always hear your mother say, oh my God, God forbid somebody's in an accident, but were they wearing clean underwear?
Yeah.
That type of thing. So it's like, okay, be preventative and get your pedicure before you go under.
Yeah.
Yeah.
I would imagine, with anything, hands, feet, especially the feet, I've seen, because some people they don't think about taking care of their feet that way, which they should. But some people just don't. And mine has nothing to do with that. It's my feet. I freeze because the OR is cold.
Yeah. And
even the, once you're in that recovery, a lot of times they'll put that, it's not a blanket, but they'll encase my body in this plastic and pump hot air because I like my blood pressure drops and I'm freezing. And then, you know, they put me in this like cocoon thing. It's like a plastic thing.
Yeah.
Bubble wrap. I call it heated bubble wrap.
I'm going to use that term with my patients. When I'm plugging them in, I'm going to be like, oh, hey, here's your heated bubble wrap. I'll have to let you know how it gets. I'm sure they'll love it. They'll get a kick out of it. That's great.
I always ask for it. I'm like, do you have the heated bubble wrap ready? Because I freeze. So like I said, we're fingers crossed that, you know, maybe it's just therapy. And that's my focus is what it, you know, hoping that I won't have surgery, but you know, if I do, we'll have to have Dr. Kaveh back on so I can update him on my shenanigans.
Oh my gosh, we can't thank you enough for coming on today, especially on your day off. We know how busy you are, dedicated to your profession, and you know the follow-up with your patients. We know they are in good hands. Any parting words, Kasu?
No, you know, I always get something just from chatting with you and listening to you. And I know our listeners and viewers are doing the same. Obviously, we reserve the right to make you a repeat offender again and come on and join with us of any new updates and things that are going on in your world as well. And, you know, you're adding so much value to people to really go into that OR with more mindset, but even a little bit of confidence and controls it, like ask certain questions and to make sure that their health, their wellness, and their mindset is in such a way that they're going to feel more confident in the hands that they're giving their own self to. And I absolutely love that. You've added so much value to so many people.
Well, as do you both. And that's why I love your show and I love everything that you guys share and the ethos. So I would, so happy we got to connect today, and I look forward to you not needing surgery, hopefully, but if you do, it's absolutely not an issue, and I'm sure you're going to thrive through it.
Yep.
For sure. And on that note, if you feeling that you want to learn more about what Dr. Kaveh does as an anesthesiologist and what he brings to not only the operating room to his colleagues, but specifically to his patients, go to his TikTok page. His videos are very informative. They're very educational, and you will enjoy watching them. On that note, my name is Janice, aka Wellness Diva 5.0, and I'm with
TwoSistas, and this is Carol, so aka Naughty Boss, live from Vero Beach. A little cloudy going on here, but that's okay. It's warm. We're not freezing our tootsies off like somebody back up north. Everyone have a great weekend. Remember, sailing into Saturday with kindness, hope, positivity, and this is one of those Zooms that you're going to have to replay because you're going to get a lot of great information from Dr. Kaveh. Thank you again so much, and we look forward to having you on again. Everyone have a great weekend. Take care. Bye-bye.
Thank you.